Hello, good morning everyone from Indiana University and also good evening people from Thailand and in Southeast Asian country. So welcome back for the episode 4 of the lecture series broadcasting from IU Indiana University from Indiana, USA. So today we are going to talk about one of the most challenging topic in my opinion. It is a very small joint that has a lot of detail and like a special treatment options. So today we are going to talk about the comprehensive review for the imaging of the TMJ or temporal mandibular joint in children. And we have like one of the best team, great speakers joining us today. This is a great team effort to building this lecture series together and also help the patient in Indiana and in this area with the problem with the TMJ. So first we have Dr. Shaun Matthews, who is a chairperson of the Oral and Maxillofacial Surgery and Hospital of Dentistry from the Dental School, Indiana University. And we also have Dr. Susan Ballinger she is a clinical director for the Pediatric Rheumatology section at Riley Children's Hospital. And at the end, we're gonna wrap up with Dr. Mosier. She is the ENT expert for us who know everything about the TMJ and build up the protocol for us and gonna tell us about the imaging checklist on what we need to know about when we read the TMJ, which is a very challenging topic. So first, I'm gonna give the floor to Dr. Shaun Matthews as a first speaker to give us some detail about the TMJ anatomy and what can we do if the patient has some issue with the TMJ? How can you treat the patient? So welcome, Dr. Matthews.
Thank you very much. I hope you can hear me clearly.
Yes.
First of all, thank you for the kind invitation to be a part of this IOC series. It's a real privilege to be here on the other side of the world, lecturing to colleagues in Thailand and Southeast Asia. And what my task is over the next half an hour or so is, as a TMJ surgeon, as an oral and maxillofacial surgeon myself, is to tell you a fair bit about the temporomandibular joint from the surgeon's perspective, both operatively, clinically, and radiologically. So I'm going to share my screen and hopefully this goes through fairly smoothly. Okay. There we go. Can you see my screen? Can you see my screen?
Yes, yes, we can see your screen.
Okay. Very good. All right, now let's minimize that. All right, so there we go. There we go. Hopefully, again, you can see it now in full screen mode.
Yes.
So I am an oral and maxillofacial surgeon. I'm chair and clinical professor of oral and maxillofacial surgery in Indiana University at the School of Dentistry. My work straddles both the medical and the dental world, and I've been privileged to work both with Dr. Ballinger and Dr. Mosier over the last nearly 2 years on the wonderful initiative that we have at our school and at our university, where we treat children with TMJ disorders, especially with juvenile idiopathic arthritis. So what I propose to do is to frame my lecture as follows, to talk to you a little bit briefly about TMJ anatomy, which I suspect will be covered in far greater detail by Dr. Mosier. Same about TMJ imaging from the surgeon's perspective. And then I'll go through with you an algorithm for how I treat patients with temporomandibular dysfunction, TMD, temporomandibular dysfunction, and show you some clinical photographs, not just my algorithm, how that is managed, both from the non-surgical to the minimally invasive to the more invasive surgical part of the algorithm. And then finally, I'll wrap up by talking about two of the most common clinical entities that we see in TMJ problems, jaw joint problems, that is the clicking jaw joint, evidence of internal derangement of the jaw joint, and finally, recurrent TMJ dislocation. So the first thing to start off by saying is that TMJ disorders are extremely common in the population. Depending on what literature you read, anywhere between 25 to 40% of the population will at some point in time in their lives have problems with their jaw joint. So it's a very common problem. It's like backache, it's out there. Apart from that, up to 75% of the population will have at least one recordable sign of temporomandibular dysfunction. That may be pain, it may be clicking, it may be locking, it may be grinding or crepitus of the jaw joint, this type of thing. So 3 out of every 4 people will complain if you ask them of one recordable sign of temporomandibular dysfunction, TMD. The typical TMJ patient is female, is 3 times more common in women than men, and usually between the ages of 20 to 40 is its peak age of incidence. Now, here in the United States, where we're based, we have a population of about 330 million people, thereabouts. So 5% of the population, something like 16.5 million people, will require treatment for the TMJ problem. So it's a lot of people. It's a busy place, and also it's a very common problem. And 5% of that 5% will actually undergo surgery by someone like myself. So somewhere in the order of about 850,000 people in the US will have TMJ surgery during the course of a year. So again, it's a common problem we see in dental schools and in various surgical and medical clinics throughout the United States. Now, a bit about the anatomy. The TMJ is a complex joint. It's a synovial joint, as I'm sure you no doubt know. The joint is an encapsulated structure, so it's surrounded by the fibrous capsule, and within it, it is bathed by synovial fluid and lined by synovial membrane. The articulating surfaces of the joint that move over each other are lined not by hyaline cartilage, but by a much more robust fibrocartilage. The TMJ is arguably the most used joint in the human body. Even when we are asleep at night, we use that jaw joint, whether it's through grinding our teeth, through talking in our sleep, we're using it almost all the time. Now, the TMJ itself is divided into an upper and lower jaw joint compartment by the all-important fibrous articular disc, or the other term for it is the meniscus. So if you look at the diagram on the right-hand side of my image, I'm not sure if you can see my cursor, this pale gray structure here, that is the articular disc, or the meniscus is the other term for it. So above the disc is the superior joint compartment, and below the disc here is the inferior joint compartment. The other important structure of note, of course, this is the bony part of the jaw joint, the mandibular condyle. But shown here in red is the all-important lateral pterygoid muscle, the jaw opening or jaw protrusive muscle of the temporomandibular joint. Now, it's important to note that this muscle has got 2 heads, a superior head, shown here, which inserts into the disc itself, and the inferior head shown here, which inserts into the medial aspect of the condyle itself. So when this muscle, the lateral pterygoid muscle in red, contracts, it pulls the disc and the condyle downward and forward out of the fossa, the glenoid fossa, on opening, and the two move together. It's like a marriage. The disc / meniscus moves with the condylar head as the jaw joint moves downwards and forwards in jaw opening, and then backwards and upwards in jaw closure into the fossa itself. On the left, the bony anatomy is clear to see, and you can see where the mandibular condyle, shown by my cursor, is in close proximity to the external auditory canal. It's actually not difficult to see why patients who've got TMJ problems may frequently present to an ENT, an ear, nose, and throat surgeon, thinking they've got an ear problem when in fact it's not, it's a TMJ jaw joint problem. Now, the TMJ itself has got multiple stabilizing ligaments, some of which are shown here on the diagram on the right. This is the stylomandibular ligament shown by my cursor, the sphenomandibular ligament, the various other ligaments like collateral ligaments, capsular ligaments, and so on that stabilize the joint, keep the condyle cocooned in its fossa, stabilized in its fossa so it doesn't dislocate readily. On the left, again, we show here the articular disc or the meniscus, and the superior head of lateral pterygoid and the inferior head of lateral pterygoid as previously described in the last slide I showed you. So not only is it a complex joint, but it's also a unique joint for two very important reasons. If I were to ask you to flex your right elbow and your left elbow separately, you can do that. If I were to ask you to bend your right knee and your left knee again, you can do that separately. They work independently of each other. The same with our hip joints and so on. However, you cannot move your right jaw joint unless your left jaw joint also moves. It's impossible. They cannot move independently. And that is because both the right and the left temporomandibular joint are joined by this bar of bone across the middle of our face called the mandible. So in that respect, the TMJ is unique in that both joints have to work together. They cannot work independently of each other. The other important feature of the temporomandibular joint is the fact that its movements are dictated not just by the shape of the joint and the soft tissue and the muscles and the ligaments that insert into the joint, but it's also dictated by this concept, this important concept of what we call occlusion. When we talk about occlusion, we mean the patient's bite, the way the teeth meet together. And again, that is a unique characteristic of the temporomandibular joint. Now, as a TMJ surgeon, there are two structures in particular that are the enemy, that are my enemy when I'm operating and navigating around this joint. The first is shown here. It's called the facial nerve, which I'm sure you all know well. The prosection on the right shows the intimate relationship of the facial nerve and the different branches, of 5 main branches, which are ramifying, spreading across the face to supply all the muscles of facial expression. And you can see C is obviously the condylar head and AE is the articular eminence, the importance and the intimate relationship of these 5 main branches of the facial nerve to the condyle. They need to be navigated and protected so they're not damaged during the course of a TMJ surgical procedure. The next main structure that I want to avoid when I'm doing my TMJ surgery is, of course, the maxillary artery, which is a terminal branch of the external carotid artery. And in this axial slice of a patient with an ankylosed temporomandibular joint, it's impressive to see that here we have, if you can see my cursor, a rather large featureless blob of an ankylosed condyle, which does not look like a condyle at all. It's lost its anatomy completely. But very close to here, shown by my cursor, is the maxillary artery running, almost kissing the medial aspect of the condylar head in extremely close proximity to that condylar head. So in an ankylosed joint, if I'm going to resect this condylar head to allow the patient to open up their mouth and release the ankylosis, I have to be extremely careful to navigate and avoid resecting straight through this maxillary artery, which of course would bleed profusely, and then we're into a major surgical clinical problem on the operating table. This schematic also shows the same said thing. Highlighted in blue is the internal maxillary artery, and in this case, it's 1.6 millimeters medial to the head of this ankylosed condyle, shown here in red. You can understand that we're playing with extremely small distances. Now, a little bit about TMJ imaging. I won't touch on this too much because I'm not the expert on this. I know quite a bit about it, but I could not walk in Dr. Mosier's shoes, that's for sure. In the algorithm of what we look for when we are imaging a TMJ, I almost always would start with a plain dental radiograph called a panorex or panoral X-ray, which I'll show you shortly. The CT scan, both a medical grade CT scan and something called a cone beam CT scan, which essentially is a dental equivalent of a medical grade CT scan. And most dental practices in the United States and high-end dental practices these days will have a cone beam CT scan machine in their offices because it gives very good anatomical detail of whatever anatomical part one is imaging. The 3-dimensional CT scan gives additional images in 3 dimensions, volumetric analysis of a joint. And finally, of course, the MRI scan, which is the gold standard imaging of the temporomandibular joint. So here we have a panoral or panorex X-ray, which gives a panoramic view of the oral cavity stretched out before you, showing the upper jaw, the lower jaw, all the various teeth. We have a condyle shown here on the right, and if we look at the left-hand side, this condyle is grossly abnormal because it's fractured and dislocated out of its glenoid fossa. So this is a very good screening radiograph for not just the upper and lower jaw, but also for the bony part of the jaw joint. But I will almost always start with this in clinical practice. The CT scan, again, you all know well, in various slices, axial, sagittal, coronal, and so on, gives specific imaging detail of the condyle. The sagittal view here on the right shows a very nicely seated condyle. In fact, good joint space preserved around the condyle itself, proximity to the external auditory canal, articular eminence, and so on. So again, CT scan, very good for giving good bony anatomical detail. So I will always go to it for that reason, clearly. Then we have a 3-dimensional CT scan, which gives in real time expectations of what one sees when you get into the joint. On the left is a medical grade CT scan of an ankylosed patient. So the condyle is fused to the base of the skull. There's no discernible anatomical detail. It's just basically a mess, essentially. This is a fused ankylosed jaw joint on the left. On the right is a cone beam CT scan, the dental equivalent essentially of a CT scan, a CBCT, of a patient with JIA, with juvenile idiopathic arthritis. This is a 16-year-old showing gross degeneration of the condyle and no normal anatomical detail, and certainly no condylar anatomy of note because it's been eroded away by the pathological process that is JIA. And finally, the MRI scan, the gold standard imaging of the temporomandibular joint. On the left, we have the various features that one looks for. Simplistically, the condylar head. Here we have the superior and the inferior head of the lateral pterygoid muscle, the kind of wispy appearance of the articular disc shown here by my arrow. And on the right-hand side, a nice tip that I was always taught by some of my neuroradiology colleagues is to determine whether there is displacement of that articular disc, is to superimpose over the head of the condyle the face of a clock, and the posterior pole of the articular disc is shown here by the arrow. This is the anterior pole shown over here. In a normally sighted articular disc, the posterior pole should sit at roughly position 11 o'clock on the face of the clock superimposed over the mandibular condyle, as shown here. But again, I'm sure that Dr. Mosier will go into far more detail on this subject. So the MRI scan clearly is our go-to imaging for the TMJ. On the left here, we have a normal-looking, beautiful articular disc. It's typical biconcave structure. It looks like a bow tie, but it's narrow in the middle and wider at the extremities, both posteriorly and anteriorly shown here. It is essentially like the wings of a butterfly. That's a normal-looking disc. On the image on the right, we have an anterior disc that it is displaced without reduction. Much more difficult to see, but just outlined here. It is slipped anterior to the head of the condyle and is anteriorly displaced disc. This one does not reduce on mouth opening. So as a surgeon, when I have a report from a neuroradiologist and I am looking for the various important structures that determine whether I want to operate on that joint, what I'm looking for in my report is as follows. I'm looking for some information on that condyle, the appearance of the head. Is it rounded? Is it normal in appearance? Is it flattened? Is there evidence of osteophytosis? Is it volumetrically normal? What is the position of the condyle? Does it translate fully on opening and closing? I'm looking for dynamic views that will demonstrate the normal opening and closing posture of that condylar head. What about the disc? What does the disc look like? Does it have its typical biconcave shape? Is it attenuated? Is it thinned? Is it perforated in appearance? Is that disc displaced? And if so, does it reduce or does it not reduce? Is there evidence of fluid? Is there any fusion in that joint? Is there evidence of synovial enhancement suggestive of intrinsic arthritis? What is the appearance of the retrodiscal tissues? These are the kind of features I like to have described on a good MRI report from my neuroradiology colleagues. Now, what I want to do is take you through my algorithm, my surgical algorithm for treating patients with temporomandibular dysfunction. Almost always, it will be conservative or non-surgical in management first. It's important that I have an objective measure whether that patient's symptoms are improving or not. So I have a measure of their pain scores, like the Visual Analog Scale for Pain, the VAS, or the BPI, which is the Brief Pain Inventory, is another index I will also use to annotate the patient's pain over the TMJ clinically. Functionally, I want to measure their mouth opening, their lateral excursive movements, their protrusive movements, or you can use something along the lines of the patient-specific functional score, which is an index, a validated index of function for the TMJ. To have an objective measure whether the patient's getting better or worse. The conservative non-surgical management can take several forms. Simple reassurance that they don't have anything terribly wrong with their jaw joints can often be enough. Patients worry about whether they have pathology in their joint, like something sinister, like a cancer. Adherence to a soft food diet. Prescription of non-steroidal anti-inflammatory painkillers. Physical therapy is key to the conservative management of a TMJ problem. The wearing of a bite splint, a night guard at night for those who grind their teeth, or bite raising appliance, as shown here in the image on the right, is also important in the non-surgical management of patients with TMJ. Balancing the occlusion, getting a restorative dentist to look at the patient's dentition and make sure that both the upper and lower teeth occlude in a normal way and have a nice balance right to left overall occlusion or bite. So once the patient's been managed for 6 months conservatively, I will then ask myself the question, so we're going down the right arm of the algorithm here, if that patient's symptoms are improved after 6 months of conservative management, then I will discharge them from my care because they're better. If the answer is no, they have not improved, then I go down the left arm of the algorithm, and then and only then will I get an MRI scan to look internally at the jaw joint for evidence of internal derangement. Normally, the imaging we use, or I prefer, is that of the dual echo imaging variety, where it's a combination of a T2 weighted image and proton density, looking for joint effusions and disc displacement, essentially. So dual echo imaging. Once MRI scan has been done, I then ask myself the question, does that MRI scan show evidence of internal derangement on the MRI scan? If the answer is no, there's no evidence of internal derangement, then we will refer the patients to a TMJ Institute clinic that I established at IU, School of Dentistry, which is a multidisciplinary clinic where we are seeing patients collaboratively, both as surgeons, orthodontists, prosthodontists, psychiatrists, physical therapists, general dentists, and so on, all at the same time in the same place, collaborative care. So those patients, those intractable patients, are being managed in that kind of clinic with very good results. Now, if the MRI scan shows evidence of internal derangement, then I go down the left arm of the algorithm here, and I will undertake the first surgical intervention, which is minimally invasive, which is a jaw joint washout procedure or lavage procedure called an arthrocentesis. And the arthrocentesis will be described in the next few slides. This is how we wash the jaw joint out if there's evidence of internal derangement on the MRI scan. So here you can see the first stage of arthrocentesis. We are inserting a needle into the superior joint compartment. The patient's condyle and jaw is being held forward in protrusion by my assistant. My thumb is on the zygomatic arch, which is being palpated. The needle is hitting the facial surface of the zygomatic arch, and then I'm nudging the needle down to enter the superior joint compartment above the articular disc. This is all done purely by feel. It's a blind procedure, and the needle that's being used is an exact same needle that's used. It's usually about 21 gauge needle that's used if you are drawing blood from a patient for whatever reason. So this is the first stage of the TMJ arthrocentesis or jaw joint lavage procedure. Now, in the very next video, I want you to look carefully at the patient's lower jaw. Once this needle is inserted into the superior joint compartment, we then are going to insufflate the upper joint compartment, literally to distend the upper joint compartment, and look at the lower jaw on the next slide. So we attach a 10 cc needle, and you can see the lower jaw is pulsing backward and forward. We are essentially creating an effusion in that joint compartment. So we know, because the mandible is pulsing backward and forward, that we are in the right place. This is exactly how you do an arthrocentesis. And the fluid in the syringe, which previously was clear, normal saline, has become turbid because synovial fluid has backed up into the syringe. And that's another way of confirming that we are in the right joint compartment. We put our second anterior needle into the joint compartment in the same as we did first. As we flush the joint out, as we lavage the jaw joint, this is the perfect arthrocentesis. Fluid goes in through the back and out through the front, and we are washing out, getting rid of all the cytokines and all the inflammatory mediators that cause pain within that joint. And that's a true arthrocentesis lavage procedure. I hope that's clear. Now, once we've done that, I then ask myself 6 months later, has the patient's symptoms improved? If the answer is yes, they are better, then I discharge them from my care down the right. On the left, if the answer is no, they're still no better, Then I ramp it up to the next stage of the algorithm and do a TMJ arthroscopy procedure, where we're putting an arthroscope in the joint and visualizing the internal anatomy of that jaw joint. So this is an example of one of the arthroscopes that I use. It's small. It has an internal diameter of 1.2 millimeters, so it's very small, similar to the needles that we use when we're drawing blood. This is the base unit shown here with a monitor, which you can review when looking at the internal anatomy of the joint. This is a fairly new scope called the on-point scope, and it gives very good internal anatomical detail of the jaw joint. It's important to know what the Wilks classification is. It is a classification of internal derangement of a jaw joint. It's one that both as surgeons and neuroradiologists one should use. It comes in 5 stages. Stage 1 essentially is a normal joint, if you like. Stage 2 is a joint that's painful and clicking, but still functional. So it's a painful, clicking, but functional jaw joint. Stage 3, as it increases in severity, is shown down here on the bottom left-hand side, is a joint that locks, but does not show any evidence of bony changes on the condylar head. It's locking because that articular disc shown here in blue has slipped anterior to the head of the condyle, so the joint sticks because of the physical obstruction of that condyle in moving forward because of displaced articular disc. That's stage 3. Stage 4 is similar to stage 3, but this time we are seeing evidence of bony changes on the head of the condyle of osteoarthritic degenerative joint disease, as shown here in stage 5, and an anteriorly displaced disc, so the joint is locking with bony changes. And stage 5 is end-stage joint disease, where everything that can go wrong has gone wrong within that joint. So it's a terminal end-stage affected joint. This is the Wilks classification. I implore you to know about this. The surgical sequence once we're in the joint with the arthroscope is to do what's called a diagnostic sweep, lysis and lavage, to break down the adhesions in the joint with the tip of the scope, to lyse the adhesions, then to flush or lavage the joint out with the fluid of choice, normal saline or Ringer's lactate. Once we've done the diagnostic lysis and lavage, we then put medication into the joint, and the 2 types that can be used, which we'll discuss in the next slide. And then we manipulate the joint aggressively while the patient is either sedated or asleep to help improve the movement of that jaw joint. So these are the 4 stages of surgical sequence when we're doing an arthroscopy procedure. Medications that can be used are of 2 types. You can either use a steroid like Kenalog, if there is an inflammatory component in that joint, like a rheumatoid patient or a GIA patient. So I would typically use Kenalog, triamcinolone acetonide shown here. If there is evidence of internal derangement and it's a disc problem but no inflammatory component, I will typically use hyaluronic acid, something like Synvis, which is a natural joint lubricant, to essentially lubricate the joint. It is the hyaluronic acid is a natural joint lubricant anyway. It's essentially the WD-40 of the jaw joint world. So that is my rationale behind my choice of medication to use in the joint. Now this is inside of a normal joint down the arthroscope. We are now in the superior joint compartment, in the posterior recess. Above here, we're looking at the roof of the glenoid fossa. This is the retrodiscal tissue here, and look at the tendrils of small blood vessels traversing the retrodiscal tissue. The retrodiscal tissue is vascular, which is why we're seeing the blood vessels here in fine form. They're not engorged or hyperemic. Now, as we come forward, the retrodiscal tissue goes into the disc, and note there are no vascular markings on the disc. The disc is avascular. Above, we have the articular eminence, and we're moving from the posterior recess of the joint through the intermediate zone, the intermediate recess. This is the condyle below, and we're pushing the scope through the intermediate recess into the anterior recess of the joint compartment shown here. So we've moved the patient from protrusion into occlusion as we flick the scope from the posterior part of the joint compartment through the intermediate zone into the anterior recess, which was shown on that last part of the video. That's a normal TMJ arthroscopy. Now, once we've done the TMJ arthroscopy, I will ask myself 6 months down the line, have the patient's symptoms improved? If the answer is yes, they're better, then I will discharge the patient from my care on the right arm of the algorithm. If the answer is no, then and only then will I pick up a surgical scalpel and do some kind of invasive procedure, some kind of an open joint arthroplasty in that patient's joint. The procedure of choice is determined by what the pathology is discovered in that jaw joint. It could be a disc reposition procedure, a condylar shave, but at the very end of the road, if that is an end-stage disease joint, then I will do what's called a total joint replacement for a patient with a Wilts 4 or Wilts 5 internal deranged joint. For those of you who have never seen a total joint replacement, here is one I prepared earlier. This is what an artificial jaw joint looks like. It's a two-part system. The superior part is shown here. It's called a fossa component made of an ultra-high molecular weight polyethylene material. The inferior part is made of a cobalt, chromium, molybdenum alloy, and the two articulate as a hinge joint. So the patients can only hinge open and close via the fossa component superiorly and the mandibular component shown inferiorly. This is a total joint replacement. This is one in the flesh in situ in a patient. Again, you can see the fossa component and the mandibular component married and hinging open and closed. This is the inferior part of the mandibular component shown through one of the inferior retromandibular incisions that we use to access the joint. And this is the image of a bilateral total joint replacement shown on a Panorex radiograph, a total joint replacement. The jaw joint equivalent of a hip replacement or a knee replacement, essentially. So in conclusion, my algorithm provides clear guidelines and a nice staged way of approaching surgically how we treat patients with temporomandibular dysfunction. Like most things in life, there are exceptions to every rule. The two exceptions are patients who have an ankylosed jaw joint, bar none, need to go straight to a total joint replacement. Nothing else will work. They need surgery and an artificial joint placed. There's also a condition called an acute closed lock, where patients suddenly, their joints become closed and locked acutely, having previously been normal, because the articular disc has slipped anterior to the head of the jaw joint. And those patients benefit extremely well if caught early enough by an arthrocentesis, a jaw joint lavage procedure. So those, to me, are the two exceptions in my algorithm. And this is an algorithm in glorious Technicolor. I won't go through it again, but that's step by step as we've just been through it from conservative to the end stage total joint replacement. Now, coming down the home stretch, let's talk about why do jaw joints click. Clicking jaw joints are exceptionally common in the population. Now, jaw joints click because there is a problem with the disc. That disc is either not in the right position, it's displaced, it's deformed, it's degenerate, it's a discal problem, a meniscal problem, unquestionably. If you take a history of the patient, they will almost certainly give some history of trauma to that joint, a knock or a fall, or a blow to the jaw. Some traumatic episode will be a precursor to the patient having a TMJ meniscal problem. The jaw joint will click, it will lock, it will not translate fully. By far, the most common position of disc displacement is anterior to the head of the jaw joint. So patients present with a locking, clicking disc and pain on opening. So this cartoon demonstrates that very nicely. We have a normal positioned disc or meniscus sited over the head of the condyle, and both are translating together as that patient opens and closes. Now in the next cartoon, you can see the disc has now slipped anterior to the head of the condyle, shown here. You can see why that disc, that jaw joint will not translate fully. That patient will have limited mouth opening and a click every time they open and close their mouth because of the anteriorly displaced disc, the ADD. My algorithm for treating this is exactly the same as I described earlier. Non-surgical first through jaw rest, through analgesia, through prescription of non-steroidal anti-inflammatory medications. A good physical therapist can be your best friend by far. They can help these patients enormously. Use of a bite splint in those who grind their teeth. If all those non-surgical methods fail to help resolve the patient's clicking episodes or issues, then I'll go to an arthrocentesis, the first stage of my surgical algorithm, and wash that jaw joint out. If that doesn't work, I then go to an arthroscopy with a telescope. If that does not work, then I will go to an open joint procedure where I'll either remove the disc, a discectomy procedure, if the disc is irretrievably damaged, Or if the disc is healthy, but just needs to be pulled back into its normal anatomical position, then I will do a discopexy or meniscopexy procedure, a disc repositioning procedure to plicate and pull that disc back anatomically. I published this paper back in 2014 of a disc repositioning procedure using something called a microanchor, an Arthrex corkscrew microanchor. This was published in the British Journal of Oral and Maxillofacial Surgery. This is what the microanchor looks like shown here. It looks like a corkscrew. It's mounted on the end of essentially a screwdriver. It's tiny. It's only about 3 to 4 millimeters in length. We open into the jaw joint. This is a disc repositioning procedure. And we are putting the corkscrew, the microanchor, shown here, into the back of the condyle, into the posterior lateral aspect of the condylar head. As we insert and embed the corkscrew microanchor into the posterior lateral pole of the condylar head, the other end of the corkscrew microanchor, which is now buried in the condyle, has got attached to it a very strong fibro wire, I should say, which is extremely robust and tough. At the end of this fibro wire is a small suture needle that we use to pass through the freed up articular disc. So once the disc is mobilized and free, we then pass the needle through the mobilized disc and pull that disc back anatomically over the head of the condyle to where it should be correctly sited. So this is the mobilized disc shown here in this image. And we pass the fibro wire through that mobilized disc and pull the disc back, and that will fix the anteriorly displaced disc. We then will close up the capsule, which was previously invaded, exposed to get into the joint space, and then close the wound, insert a surgical drain, and job done. That is a corkscrew microanchor approach to a discopexy procedure for an anteriorly displaced disc. And finally, let's talk about recurrent TMJ dislocation, which is very common, and certainly should be something one's aware of, especially if treating patients clinically. First of all, recurrent dislocation is thankfully fairly uncommon, although dislocation itself is not uncommon. It has an incidence of about 1.8%. And it is seen in the elderly population, especially who just have natural joint laxity. As we get older, our joints all become lax and floppy. It's also seen in patients with internal derangement of the TMJ and those with occlusal anomalies, essentially. It is seen in patients with neurological conditions and those who demonstrate extrapyramidal motor symptoms, and also seen in patients on neuroleptic medications. So that's the category of patients one needs to be aware of who can present frequently with recurrent TMJ dislocation, where the jaw joint slips out of the fossa and dislocates. So this is an example of a patient with bilateral TMJ dislocation. On the right, you can see here, the condyle is seated well anterior to the articular eminence. This condyle should be seated here, if you can follow my cursor, in the glenoid fossa, but it's been displaced well anterior to that. On the left side of the slide, the condyle in this case is just seated underneath the articular eminence, still displaced, but not to the same degree as on the right. So again, this is a case of a patient with essentially bilateral TMJ dislocation. The patient's occlusion is gagged open, the teeth do not meet. So the condyle is anterior to the articular eminence. Dislocation can be unilateral or bilateral. It can occur in someone with a normal joint, but where there is some sudden dislocating episode. For example, if someone is punched to their jaw in the middle of a conversation while the jaw is open, that will dislocate their jaw joint, which otherwise is anatomically and pathologically normal. It can be seen in patients with pathological joints where there's natural joint laxity of the ligaments we described earlier and excessive condylar movements. For example, the elderly patient. There's no specific inciting dislocating episode in these patients. Things are just loose. Now, for the dislocated jaw joint, patients cannot get their teeth together. The teeth will not touch. They'll be gagged open in occlusion. If the dislocation is unilateral, the midline of the patient's mandible will be deviated to the contralateral side. If, of course, the jaw joint dislocation is bilateral, then the patient's mandible will be centered in the midline. It will not be deviated to one side or the other, but the teeth will not meet. The condyle can often be palpated anterior to the articular eminence. It's a clinical diagnosis. But of course, you can take radiographs to confirm the diagnosis if you so wish, but often it's not required. One thing to be wary of when surgically I am addressing a patient with a TMJ dislocation is I want to know if there's evidence of pneumatization of that articular eminence, as shown here on the image. If you can follow my cursor on the right, image B, you can see all these pneumatized air cells which have traversed and have regressed or progressed into the articular eminence. If I'm doing a surgical procedure to reduce that eminence, to avoid any further future TMJ dislocation, I want to know before I get in there whether there are any mastoid or air cells to be avoided. So taking a CT scan pre-surgically is an extremely good idea for these reasons. So the treatment of choice, unquestionably, is first of all, you've got to locate that dislocated jaw joint back into the fossa quickly. You have a golden 2 hours to resite that jaw joint. Once the muscles of mastication have gone into spasm, trying to relocate the jaw joint is extremely difficult. It's like trying to move a block of concrete. I will use sedation or intra-articular local anesthesia frequently to help with patient's management, pain management, before I site the jaw joint. And I will immobilize the joint once it's back in position by using something like a barrel bandage, as I'll show you shortly. There are various methods described to relocate a jaw joint, but the key thing is you've got to get that condyle back in the fossa quickly. I use the Hippocratic method shown here on the left, where we are pushing down on the back teeth. So we're getting the condyle below the articular eminence, pushing back to get it behind the eminence and up into the glenoid fossa. This almost bucket handle movement. And that is the essential movement to get the condyle back into its fossa. And then reduce the jaw joint using some kind of immobilization technique like a barrel band is shown here. Very quickly, this is a surgical approach that I use when I am doing an eminectomy procedure for a patient with recurrent TMJ dislocation. We have the pre-auricular approach shown previously. We are dissecting down into the jaw joint. My first anatomical landmark is shown here. This is the temporalis fascia, this white gleaming layer of fascia. And then once we have incised through the fascia, I'm looking for these tiny globules of fat shown here that will get me into the superficial temporal fat pad. And in that dissection plane, I know that I would avoid the temporal branch of the facial nerve shown here. This is the fat pad, the globules of fat, and that's where the dissection will continue all the way down to the root of the zygoma, the back end of the zygomatic arch. That is the dissection plane. Now here we are on the zygomatic arch with my periosteal elevator. I'm now exposing the zygomatic arch because I want to look for the articular eminence. This is an eminectomy procedure where we are removing the eminence to stop that jaw joint from dislocating. Here you can see the eminence actually nicely demonstrated here and now clearly localized. The next thing I'm going to be looking for is the articular eminence. So here's the articular eminence nicely protected, that ledge of bone that the condyle gets stuck in front of when dislocated. And I want to next make my markers to allow me to decide where I'm going to resect that eminence. So I typically will use either a surgical device like a drill or piezo surgery knife to mark out my excision markings for the articular eminence, the eminectomy, as shown here. And then I'm going to join up the dots. So everything below the dotted line will be removed. That is the eminence. And it's important to protect all the soft tissues shown here. I then use a special saw called a piezo surgery saw, which cuts bone using ultrasound waves. It's a very nice, safe way of delivering this kind of surgical success. And then we are literally going to cut the bone moving from lateral to medial to remove that articular eminence. I'm going to move the video along a little bit. There we are. So we're deepening that cut more and more with my piezo surgery saw. Again, it gives a nice, safe way of cutting through bone. Move it along a little bit more. And the next thing we're going to do is take a surgical osteotome. It's a bit like sculpting, isn't it, really? And then we are going to just very gently remove the articular eminence shown here. The bone is now free, and retrieve that eminence. And now we have a nice clear ledge of bone above and no evidence for that condyle to be displaced or dislocated in front of. And that's the end result. And that is a nicely demonstrated TMJ eminectomy procedure because we have removed the articular eminence. We smooth the bone off and we have a nice clear ledge and job is done. So this is the result, the end result of the eminectomy. You can see the condyle moving backward and forward. Now it's moving nicely. You can see the stretch of the retrodiscal tissues here. This is the articular disc. There's no barrier now, no eminence for that to be stuck in front of, and there's no way that this condyle can dislocate. That's the successful TMJ eminectomy. Great. Good, and that is all I have for you. That's my offering from the surgical perspective. A walkthrough of my life as a surgeon and how I treat the more common TMJ disorders. I hope you found that to be very helpful. I'll pass it back to you now, Tanya.
Thank you so much, Dr. Matthews. That is really interesting procedure and on how you treat patients. I have a couple of questions, but we can keep it at the end. Are you going to be with us until at the end of the talk?
I will, yes.
Oh, okay, yes. So we can keep the questions to the end. So next speaker, we're gonna give the floor to Dr. Susan Ballinger in terms of the treatment for the medical treatment in the patient with JIA. So please welcome. The stage is yours.
Thank you so much. Can you all hear me?
Yes, we can hear you.
Awesome. Great. Well, again, just like Shaun said, I'm grateful for the opportunity to speak internationally. It's kind of exciting sitting here in Indiana and being able to be seen across the world. So I'm going to talk briefly about specifically TMJ in children, and specifically children with juvenile idiopathic arthritis. When I did this lecture last year, one of the feedback things was, can you present some clinical cases? So I'm going to start with 3 clinical cases just to kind of whet your appetite. I'll tell you about the patients in the beginning, and then I'll tell you actually what they all have at the end. We're going to talk very briefly about JIA, what it is, and then TMJ and JIA, TMJ imaging. Dr. Mosier is going to talk a lot more about that than I, so I will keep that brief, and then we turn to the clinical cases. So we have 3 patients to consider as we talk throughout this talk. One is a 14-year-old who was referred to our clinic that I do in combination with Dr. Matthews on Tuesday afternoons on the 4th Tuesday. So we have clinic this afternoon. The patient had jaw pain and stiffness with chewing. The second patient was a 15-year-old referred for jaw pain. The third patient is a 12-year-old referred for 1 episode of jaw locking. And at the end, I'll give you more clinical history. Actually, I'll tell you the imaging results first, and then we'll talk about clinical history to show how we backwards can figure out what these kids have. JIA has a long history in terms of its description. It was first described by Frederick Still in his first seminal article about childhood arthritis. He described TMJ involvement, but despite this, really into the 21st century, TMJ was a joint that was either largely ignored or just not well assessed. There were poor imaging options and poor treatment options. And so when I first started my career, we saw lots of kids with pretty severe TMJ involvement. The definition of arthritis, just to get very basic, is inflammation in a joint. We can see swelling, loss of function, pain, warmth, and redness. In kids with juvenile arthritis, the top 2 things we see are swelling and loss of function. The pain, warmth, and redness is often seen in other etiologies of arthritis. JIA by definition is arthritis. It's in a joint for greater than 6 weeks in a patient less than age 16. And you have to rule out other causes of arthritis, including other rheumatologic diseases like lupus and dermatomyositis, and then other causes altogether. This is my favorite slide to present because it really tells you everything you need to know about peds rheumatology. When you're thinking about a rheumatologic etiology of disease, you also always have to consider infections and oncologic disease, and then mechanical, or what I sometimes refer to as non-surgical orthopedic problem. We see a lot of patients with non-rheumatologic disease in our clinic, and we need to make those differentials so that we don't miss other more significant disease in patients. There are actually 7 subtypes of JIA. One subtype not on this list is other, which means there's a combination. And this is just to familiarize people who are not so familiar with all of our subtypes. We probably see TMJ mostly in the polyarticular subtype of disease, but we certainly could see it in any of the subtypes. Treatment in general, again, there's a stepwise, just like Dr. Matthews went through his stepwise treatment and approach. We start with non-steroidal anti-inflammatory drugs. Most patients come to us already having failed those. Disease-modifying anti-rheumatic agents are usually next in line, with methotrexate being the one. About 70% of kids with JIA will respond to methotrexate, the 30% that don't. Some just can't tolerate the medication for side effects, and some truly don't respond to it. And now in the age of biologics, which started back in 1997 with the TNF inhibitors, we can inhibit all sorts of inflammatory cytokines. TNF, IL-1, and IL-6 were the first big 3. We now have IL-17 inhibition as well as combined inhibition, and I should have up there as well the JAK kinase inhibitors. So TMJ and JIA, why should we care about this? Well, there's an association in terms of TMJ disease between stress, psychosocial distress, jaw dysfunction, and with loss of activity of daily living with orofacial pain. Children with JIA with TMJ involvement not only have longer duration of disease and higher peripheral disease activity, but they have lower oral health related quality of life scores. And that makes sense. If you can't open your mouth, you can't really get in there to do your oral hygiene, and then you end up with more disease. There is one systemic review and meta-analysis on oral health JIA in JIA patients. And again, they have more periodontal disease and TMJ disorders from lack of oral hygiene. There's a relationship between orofacial pain, orofacial health, and quality of life measures. And finally, if I didn't say this, I would have missed everything Dr. Matthews has tried to teach me over the last couple of years, and there is a known increased incidence of obstructive sleep apnea and all the problems that go along with that in kids with JIA and TMJ disease because of the way the jaw changes, and you decrease the aperture of the throat with TMJ disease. There is a frequency of TMJ disease that can be as high as 87%, probably closer to 50%, depending on the articles you read, and it varies by subcategory and varies also by how we're doing the clinical and radiographic measures. TMJ involvement can be at the beginning of disease or can develop later in disease, and it can lead to decreased growth of the mandible and micrognathia. This is kind of a classic. When I see a face like that, I think TMJ disease from JIA. But we also can see deviation on opening without micrognathia. And again, that's from the condylar abnormalities that we're going to see, Dr. Mosier is going to go through. The symptoms can be totally asymptomatic, which is hard. If they're asymptomatic, how do you know they have it? And so sometimes people are advocating routine screening and imaging of the TMJ in kids with JIA. Some kids will have discomfort, some deviation of the mouth on opening and decreased mouth opening. The problem is sometimes this is from old and not active disease. So they may come to you later on, sometimes when they're starting to get orthodontic procedures and they can't open their mouth very wide. They never realized it was a problem, but they can't hold their mouth open for a very long time, or they can't open it wide enough to get the braces even put on. These kids can end up also with poor mechanical loading in joints from old disease. The diagnosis of isolated TMJ arthritis is controversial, and part of the reason is because the MRI and CT appearance overlaps with other mechanical diseases of TMJ, and that's a nice segue for us to kind of talk about imaging. Real basic stuff, so Dr. Mosier can get to the good stuff. But we have to remember kids are different. I wouldn't be a pediatrician if I didn't point that out. And so one of the things we have to think about is the normal development and normal developmental changes that occur in the mandible throughout the transition of a child's life. The bone marrow signal changes can reflect transition from hematopoietic marrow to fatty marrow in the very young child. The mandible does mature over time, so you see kind of a 4-year-old is a very different mandible than an 18-year-old. The gold standard of imaging in TMJ in JIA is MRI with contrast because it can detect both inflammatory and osseous changes. But there are limitations, and you need sedation in younger patients. And if the child already has braces, metallic braces in particular, is really going to interfere with the imaging. And as Dr. Matthews pointed out, many orthodontists now have cone beam CTs in their office. And so often these kids start with a cone beam CT. And then if there's abnormalities there, they move on to other imaging. But the MRI can show us acute inflammation, including joint effusions, synovial thickening, and bone marrow changes, as well as chronic changes, including condylar flattening, osseous erosions, and disc pathology. In the differentials, as I said, these can be confusing. You can see adolescent idiopathic condylar reabsorption, anterior disc displacement. The imaging can be abnormal because of previous injury. And Dr. Matthews and I had one patient in our clinic where we always ask about, any injury, and the kid said no. And then all of a sudden they remembered, oh yeah, he was, hit in the face with a hockey puck right in the chin when he was about 5 years old, had x-rays done and everything at the time. So it was a significant injury that they had forgotten about by the time he was 15, but may have affected his TMJ at that point. You can see infection. Certainly there are developmental or congenital abnormalities, and like in my triangle, infection and tumors and tumor-like conditions have to be considered in terms of abnormal imaging. There was a very nice study done in 2018 where they actually looked at the normal appearance of the TMJ they compared kids with JIA and base and normal controls. I found this interesting because the normal controls they actually got from kids who were getting MRI of their head for other reasons, and they added the TMJ on as part of the study. There were 122 controls. Many of those were kids with different cancers, and they were staging for cancers. There were 35 kids with JIA. Most of the kids with JIA were very early in their diagnosis, and all were being treated. And I think that affected some of the findings, because 51% of the controls and only 29% of the kids with JIA had effusions, and that was statistically significant. There were chronic changes, though. They were not seen in 0 of the controls, so no changes in terms of condyle changes, erosions, or anything like that. But they were also only seen in 5% of the kids with JIA. And again, I think that's biased because these kids were early in their diagnosis and were already on treatment. But the conclusion of that study was that small amounts of effusions or contrast enhancement in the absence of chronic changes need to be interpreted with caution, that these certainly could be kids who just could be normal findings in kids. The 2 other articles I want to talk about, one was looking at JIA versus the idiopathic condylar resorption. And there was a study that was done in Denmark. It looked with cone beam CT. So again, not the standard that we think about in terms of imaging the TMJ. And they found statistically significant differences in only 5 measures. They measured about 20 different things. I've highlighted the measures that were statistically significant in terms of JIA in red and in green for the ICR. So TMJ pain, morning stiffness, and pain on palpation were significantly different in terms of predominance of JIA. And TMJ click and all open bite, decreased open bite were both more common in the kids with ICR. So again, some things that you can look at in terms of differentiating these kids, you'll notice that most of these differences in terms of these patients are either exam findings or history findings. And then anterior displacement of the disc. Dr. Matthews spoke about the surgical implications of that, and certainly some of these kids, this was an article done looking at TMJ changes, and there really were only 3 statistically significant differences in these kids. Again, the red ones are highlighted with kids in JA, the purple one with temporal bone changes. And these were hard because they looked at different staging in the findings, and some were more prevalent in kids with ADD and some more in kids with JA. But the conclusion was overall that really significant bony changes were more consistent with JA as a diagnosis. And just some things to keep in mind. MRI may be overly sensitive, I think is the bottom line. These changes can be consistent with minimally active disease, as in that first study I showed with kids with who were normal, essentially normal controls. And really, some people would consider the absolute gold standard would be doing MRI with arthroscopic studies for correlation. And there's sometimes not a lot of correlation. Joint space width and hyperplastic synovitis. The synovitis enhancement ratio of synovium and hyperplastic synovitis on arthroscopy is different than an MRI. And sometimes we had MRIs that didn't show synovitis, but showed active synovitis on arthroscopy. So it's the best we have, but it's not necessarily the absolute. We're not always seeing on MRI what we see when we look at it. So again, the bottom line is the diagnosis is not made by imaging alone, thank goodness, because we still need clinicians to make these diagnoses. Sometimes the history is important, and sometimes the history of other joint issues is important. TMJ and JAA treatment. My standard is treat the underlying disease. If you treat the arthritis, you'll be treating the TMJ arthritis. So how do we treat arthritis? Well, we want to decrease inflammation. We want to reduce the orofacial signs and symptoms. We want to treat the current disease and prevent sequela of future disease, and also treat the sequela of the previous arthritis. We want to normalize dentofacial growth, especially in the child who's still growing, and we want to address the deformities. Dr. Matthews has already gone through all this, so I'm going to just kind of pass by this and then get back to the cases and finish up and hand this over to Dr. Mosier. So remember, we had the 3 patients. We're going to talk about SH first. Her MRI findings showed that she had, you can read it here, advanced degenerative changes on the left with severe flattening of the condylar head and ramus and bony sclerosis. She had moderate synovial enhancement and very limited motility. And on the right, again, similar findings. She had a little bit thinning of her disc posteriorly. And so what you need to know about SH is she also had bilateral wrist pain and swelling. She had a treatment of JAA on TNF treatment when she was referred to our clinic. She's actually a patient of mine. She had increased frequency. What we did to treat her, she was actually having a flare of her arthritis overall when she presented TMJ clinic. So we increased the frequency of her TNF inhibitor, and she had complete resolution of all her symptoms. Our plan is to follow her with serial MRIs and to consider a washout if she has worsening on her imaging, even if she doesn't have worsening necessarily in terms of her symptomatology, just because we want to minimize destruction of her joint. EP, she had no evidence of active synovitis on joint effusion. This is about the third, reading on about the third of her TMJ imaging that we did over the course of about 18 months. She had some improvement actually from her marrow edema. We had started her on treatment, and she had some partial disc recapture. She had, when we first saw her the first time in clinic, she had several month history of bilateral knee pain and back pain. She actually had presented to pediatric rheumatology clinic first. It wasn't clear what her underlying diagnosis was, but into the course of her disease, she actually developed swelling in her wrists, ankles, and knees. And so she had her initial imaging, which showed inflammation or TMJ. That, along with her other joints being involved, gave her a diagnosis of polyarticular JAA. She was rheumatoid factor negative. Dr. Matthews did a washout and intra-articular steroid injection of her TMJ, and she had a significant but unsustained improvement. So basically, she felt better for about 2 to 3 weeks after the procedure, but then started having joint pain again. So we started her on methotrexate with resolution of all her joint symptoms, including her TMJ, and including some of the joints that were not swollen, but were painful. She's recently had an increase in her pain, so we've increased her medication again. And then the final last patient that we saw was actually referred to us because she had one episode of locking of her jaw, and she had on plain film some flattening of her condylar head on the left, and some grossly flattening on the right, and that was confirmed with her MRI. She was hard. This was one of these patients that we saw. She was totally asymptomatic with no future episodes of clicking after the first one. She had no other joint symptoms. And we really thought the changes, while they could be consistent with JAA, we certainly were not seeing any active disease at the time. And because she was asymptomatic, we we decided to repeat her MRI in 3 to 6 months just to see if any changes happened. She had no change after 6 months. And so we've kind of told the family, we think this is maybe old JIA. This could have just been something congenital or maybe from an unrecognized injury. And she's going to be a patient we'll see back again as needed. So I've got a few references. This is me. If anybody has questions, you're welcome to email me or call my office. But probably emailing is a little bit easier from Thailand. So I know I went through things quickly. I wanted to make sure we left plenty of time for Dr. Mosier because it's always a pleasure to listen to her speak, as it is always informative. And I, again, appreciate the time for and the opportunity. Thank you so much.
Thank you so much, Susan, for your excellent talk as always. So we're gonna move on to Dr. Mosier about imaging of the TMJ. According to Dr. Matthews and Dr. Ballinger talk, imaging is quite important, and they have like some specific thing that they want to know from us as a radiologist. So I give the floor to Dr. Mosier.
Okay, let me just here on. Giving me some sort of privacy. Let's see if this will share this. Okay. Sorry, I'm just figuring this out.
No worries. We loved Microsoft Teams, as we all know.
Okay. All right, can you all see my screen? Okay.
Yes, I can see your screen.
Great, sorry for that. Okay, so let's get moving here. And so what we're going to do over the next few minutes is go through and review some of the anatomy and function of the temporomandibular joint. Dr. Matthews and Dr. Ballinger have gone through some of this, and Dr. Matthews has elegantly shown some of this, both in diagrams as well as his surgical findings. We're going to talk specifically about the articular disc and in the setting of degenerative joint disease. And then we'll just finish up with a brief discussion about other inflammatory conditions. So one of the things, and as Dr. Matthews talked about earlier, to remember about the temporomandibular joint, it's unique from other joints in the sense it's a diarthrodial synovial joint. This is the articular surfaces are all covered by fibrocartilage. And remember that this disc or the meniscus is actually composed of fibrocartilage as well. So when we look at our schematic diagram of the temporomandibular joint, if we look at the osseous components here, we see the mandibular condyle articulates within the glenoid fossa. It is formed as part of the squamous temporal bone and zygoma. In the root of zygoma, we see the articular eminence anteriorly. And this is all enclosed by this fibrous temporomandibular joint capsule. This attaches both to the zygoma as well as the neck of the condylar and condylar head. And the capsule encloses the entire temporomandibular joint. The anterior part of the capsule actually attaches to the superior belly of the lateral pterygoid muscle, as we see here. So this encloses the entire temporomandibular joint, forming also these synovial compartments. So we see that we have a smaller superior and small inferior joint compartments that are all lined by synovium, and we'll see a better diagram of this a little bit later. So when we look at the innervation of the temporomandibular joint, as we see diagrammed here and on the right, really the capsule is innervated by two different branches. We see that it's the interlateral aspect of the temporomandibular joint capsule is actually innervated by the masseteric branch of B3, whereas the remaining lateral aspect of that capsule is actually innervated by the auricular temporal nerve. As you see, this comes around behind the mandibular condyle. So as we look at this lovely diagram of the temporomandibular joint, again, notice the mandibular condyle articulating within the glenoid fossa here. So one of the things that we're evaluating is these osseous relationships between the mandibular condyle and the glenoid fossa and articular eminence. We see this enclosed by this fibrous capsule, again, attaching to the superior belly of the lateral pterygoid muscle. And within this, the articular disc that we see has this bow tie shaped appearance to it that Dr. Matthews very nicely showed earlier. Our smaller anterior band, the intermediate zone, and the posterior band. This is attached posteriorly to what we call this bilaminar zone, which again contains the vascular innervation that Dr. Matthews very nicely showed us on his arthroscopic views earlier. So when we look at a close-up view here of a cadaveric specimen of the temporomandibular joint, and we see the mandibular condyle here articulating within the glenoid fossa, or articular eminence anteriorly, we see this fibrocartilage disc. It's a vascular connective tissue disc. And we break it down into 3 zones: the anterior band here, this thinner intermediate zone, and then the posterior band. Notice that the bulk of the posterior band is really centered over the high point of the condyle, or as Dr. Matthews talked about earlier, if you could superimpose a clock face on this, it would be about the 12 o'clock position. So just remember that it's really over the most superior portion of the condylar head. That's a normal position of the articular disc in a normal joint. So again, the anterior band attaches anteriorly to this capsule, and thus the superior belly of the lateral pterygoid muscle. We see our retrodiscal tissue back here, our vascular innervation of the temporomandibular joint. And again, we see this here in another cadaveric specimen. I'm going to show you in a moment a cine movement on a cadaveric specimen of the temporomandibular joint made by my colleague, Per Leonard Westerson from the University of Rochester. So here we see, we're going to look at the dynamics of the joint. What I want you to notice is the rotation of the condylar head and its translation down behind the articular eminence and out, and how the articular disc, which we see right here, is going to pop back over the top of the condylar head. That's a completely normal movement. So watch the condylar head rotate and translate, and see how the disc comes back over the top of the condylar head. So that's a normally functioning joint. And we see this illustrated here. Again, our normally positioned articular disc over the top of the condylar head. We see this rotation of the condylar head in translation with the disc popping back over the top of the condylar head. And this is a normal reduction of the articular disc and a normal movement of the joint. So how do we image the temporomandibular joint? Well, as we've discussed earlier, as both Dr. Matthews and Dr. Ballinger have discussed, really our gold standard for imaging of the temporomandibular joint is MR. We're really only reserving CT to look at the osseous elements if we're really concerned about detailing the osseous involvement, although we can certainly identify that on MR. Here in the States, we don't do arthrography because we have such wide availability of MR. That being said, this is an arthrogram that I did a few years ago because this patient had a cochlear implant that was not compatible with MR imaging. And you can see, so what I've done is obviously inject contrast into both superior and inferior joint space compartments. And we can see that we outline the articular disc very nicely here by injecting contrast within the joint space compartments. So how do we do MR imaging of the temporomandibular joint? Well, here, because we have wide availability of multi-channel coils, we use those. We used to use surface coils, and if you have those available, those are actually very nice. They give you nice high-resolution views of the temporomandibular joint. But if you've got multi-channel coils, certainly those also give us very nice high-resolution views of the temporomandibular joint. And the way that we acquire the images, we're going to do corrected oblique, sagittal, and coronal thin section images, 2 to 3 millimeters. We're going to use T1 proton density and T2 images, and we really rely on the proton densities. Those give us better signal in terms of looking at the articular disc. And these we acquire in the closed position and the open position. We also acquire coronal images in the closed position. We do give contrast pretty routinely because we see a lot of these patients, particularly the pediatric patients, where we are concerned about the degree of synovitis. But really, we're only giving contrast if we have a concern for synovitis, we have a concern for acute infection, or of course, neoplasms. So just some older images here looking at the orientation. So this is how we acquire our sagittal images. This is going to be perpendicular to the long axis of the condyle, and how we acquire the coronal images. Those are going to be along the long axis of the condyle. So let me just go back here really quick. This is an older T1 weighted image of an adult with a normal condyle. We see normal rounded profile of the superior aspect of the condylar head, nice intact cortical bone, and we see this bow tie configuration of a normal articular disc, this hypointense T1 signal. as we see outlined here. So again, we talk about normal positioning of the articular disc, and as we mentioned before, this posterior band really is about the height of the condylar head, or the 12 o'clock position. And really what you'll see is a variability across normal joints, both in the pediatric and adult population. So really, even if the posterior band is about 30 degrees in front of this height of the condyle, that's still within the range of normal. So really at the 0 degree point, or at the height of the condylar head, or the 12 o'clock position to 30 degrees anterior, would be considered a normal joint, or a normal meniscus position. So on opening, as we said, what we're looking for is rotation and translation of that condylar head. Let me go back here. And we want that articular disc to pop back over the top of the condylar head, as we see here. Here's our bow tie configuration in the opening movements of this joint, where we see the articular disc popping back over. So this is a completely normal joint with normal reduction of that articular disc. Now, one of the other things that we do here, and I think it's important, is to do dynamic imaging of these patients. And, you know, sometimes it's a little bit more difficult in some of our younger patients with their ability to cooperate. And the reason that we do this, it gives us a good view of the dynamics of the joint mobility, because sometimes we don't always get a good view of this, or representative view on dynamic or static imaging, as we see here. So we have this patient proton density image in the closed position. Here's our articular disc over the top of the condylar head, normal position of the condyle and the articular fossa. As we look in opening, we're not seeing really any movement here. So in the opening, as we acquire with static images, we put a syringe between their teeth to open up those jaw joints, and you see there's really not any movement here. But if we look at the dynamic images, which we acquire with a dynamic haste technique, you'll see we get nice movement of that joint, and we see that there is reduction of that articular disc over the top of the condyle. So it's really important to incorporate dynamic imaging into your assessment of the temporomandibular joint. So what I want to do now is just go through a number of patients and looking at the spectrum of disease presentation in terms of both the osseous pathologies that we find, as well as internal derangements. So we're going to talk more about this. So this was an adult patient. And we look here, we have normal position of the articular, of the condylar head within the glenoid fossa. Nice intact cortex here, really no. So completely normal condyle. We see the articular disc here, normal position here. Maybe a little bit of a joint effusion on our T2 weighted image here. And then we see on opening that the condylar head is just a little bit beyond the height of the articular eminence, with a normal reduction of the articular disc. So really what we have here is a little bit of subluxation or dislocation of this temporomandibular joint. Now, as Dr. Matthews talked about earlier, this is an older patient. He does have a history of jaw pain, but it's not unusual in older populations to see a little bit of subluxation or dislocation in these patients. And this is an otherwise normal joint. So when we talk about temporomandibular joint disorders, this really is a spectrum of disorders. So this includes degenerative joint disease, internal derangements. We talked a lot about arthritis. Dr. Ballinger is an expert in arthritis, and particularly in treatment of pediatric arthritis. This also includes muscular disorders, oral facial pain. So broad spectrum of disease presentation. And as Dr. Matthews pointed out, this really affects a large percentage of the population. So when we talk about internal derangements, what does that really mean? Well, this refers to displacement of that articular disc, or the meniscus, and whether or not we get normal reduction of that articular disc or meniscus on opening movements. We also can see morphologic changes within that disc, and that just can, we start to see breakdown of those fibrous connective tissue elements, so that becomes dysmorphic in its appearance. The morphology changes. We may see fibrosis or perforation of the disc. So internal derangements we tend to see more frequently in the younger adult population, although again, we see this both in kids and as older adults. Typically, they present with preauricular pain, some limitation on opening, trismus. We may hear joint sounds, and that includes grinding, this clicking or popping sounds. This is very often associated with degenerative joint disease. And again, very prevalent in the normal population. Osteoarthritis is progressive cartilage degradation, where we'll see subchondral bone remodeling. We may see chronic synovial inflammation. And on imaging, what we're going to see is loss of that normal rounded convex appearance of the condylar head. So we flattening of the superior surface of the mandibular condyle. We may see osteophytes, we may see focal erosion or sclerosis in more advanced cases, and subchondral cyst. And I like this diagram because it really just shows the spectrum of what we see in terms of degenerative joint changes across varying stages of disease. So again, normal condylar morphology with rounded superior surface here. And as we start to see early degenerative changes, we have loss of this cortex and flattening of that superior and anterior surface. This would be mild degenerative changes. We see more progressive changes here, greater flattening, irregularity. This is moderate and more severe. We really have severe flattening of that condylar head and erosive changes. And what you're seeing the last two panels here is with resolution of inflammatory etiology, we start to see recontouring of that mandibular condylar head. Now, in the way that we approach interpretation of the imaging is a specific template that we follow. So what we want to do is really assess all of these categories. So we want to assess the condylar position and morphology. We need to assess the marrow. We need to look for joint effusions. And of course, we need to look at the articular disc, both its positioning and whether or not there are morphologic changes. We want to, in the presence of contrast, look for synovial enhancement, and of course, assess the mobility. So we really want to look in the condylar position. Is it sitting symmetrically as we acquire the images in a closed mouth position? Is it sitting symmetrically in the glenoid fossa? Do we have any degenerative changes? So do we have flattening, and what degree of flattening, a loss of cortication is there? Do we have any osteophytes? We want to look for evidence of marrow edema. Whether or not there's sclerosis or in rare cases, avascular necrosis. We want to look for the presence of joint effusions. And again, assessing the position of the articular disc, whether it's displaced and whether or not there are morphologic changes, and then degree of synovial enhancement, if there is any. And then our mobility. Is there rotation of the condylar head, and are we getting translation? And to what degree are we getting translation, or is there abnormal mobility in the sense that there's subluxation or dislocation? So let's go through and look at some examples. This is a patient with mild degenerative joint changes. So we look on our T1 weighted image here. We see flattening of this anterior superior aspect. The cortex is really pretty still intact. We see anterior osteophytes, and you can see that this is a normal position of the articular disc with our posterior band at the height of the condylar head. When we look in the coronal images, we do see, there is a more obvious loss of cortication on this lateral pole, some sclerosis here. We see that the articular disc actually is a little bit what I call a little bit redundant on the medial aspect. So it's not really displaced, but it's just a little bit of redundancy on the medial aspect. And we see on opening, there is some rotation, not a lot of translation with normal positioning of the articular disc. On another patient, now we see in this case that, if we just go back, we've got a little bit of marrow edema, as we see here on the T2 weighted image. And we've got a little bit of joint effusion here. It's hard to see in the T2 weighted image. It's just a little bit of about 30 degrees anterior. So it's kind of normal, maybe minimally displaced. And we see that on opening, we're getting some rotation and translation with really not with complete reduction of that articular disc there. This is an adult patient with jaw pain and limitation on opening. And again, we see a little bit of flattening here, a little anterior osteophytes. And we see that the articular disc is displaced, but does not reduce on opening. Okay, so when we look at morphologic changes in this patient, we see it a little bit better here on our proton density. You see flattening of this superior aspect, anterior osteophytes. And we see here, although the disc is normally positioned, you start to see a little bit of increased T1 signal and maybe a little bit of irregularity of this anterior band and intermediate zone here. So a little bit of dysmorphic appearance to it. We see here some rotation on our opening, but again, without reduction. When we look at joint effusion, as we see in this patient, again, our condylar head looks pretty good here. So really mild degenerative changes here. Our disc is anteriorly displaced. In this case, you see how this posterior band is really significantly in front of the condylar head, and we see a superior joint space effusion here with the fluid signal in our superior joint space. As we get on to a more significant internal derangements and degenerative joint disease, in this patient, we see some flattening here, anterior beaking here. Some mild edema within the condylar head. And as we see in our T2 weighted images, we have both superior and inferior joint space effusions. our articular disc is anteriorly displaced, and we see on opening that the articular disc remains anterior to the condylar head. Now, this is a 12-year-old female with jaw pain, and again, we see some loss of cortication, a little bit of flattening, so degenerative joint disease. Our articular disc is displaced anteriorly, and you see that here. Again, notice the joint effusion in superior and inferior joint space, and we see that disc remains really balled up in front of that condylar head on opening, so anteriorly displaced without reduction. And again, looking at more severe cases now, this is an older adult patient. You see here the condylar head is actually pushed back a little bit in the condylar, in the glenoid fossa. The articular disc is anteriorly displaced, and we see here really much more significant superior joint space effusion. You see how this disc is now really just balled up anteriorly, so very dysmorphic. And again, on opening, we're not seeing reduction of that articular disc over the top of the condylar head. On this patient, this is a 17-year-old female with a history of jaw pain and a positive history of juvenile rheumatoid arthritis. Now we see really for a 17-year-old, I would say moderate flattening here and anterior osteophytes. In a younger patient, this is a more significant change. The disc is anteriorly displaced here, and again, very dysmorphic, maybe a little bit of perforation here. You see on opening again, we're really only getting partial reduction of that articular disc. Now, this is a more severe change in a different patient where we're seeing really severe loss of cortical height here, some irregularity and loss of cortication. Our disc is anteriorly displaced, actually perforated and balled up here, and you see that here on our T2 weighted image with significant superior joint space effusion and no reduction on opening. Now, this is the other side of that 17-year-old that I just showed you a minute ago, where we see a much more severe appearance on this side. We have more severe degenerative joint changes. You see the loss of cortical height here on this mandibular condyle. The disc is anteriorly displaced and actually not even identifiable. It's all disintegrating. You can see here on this image here how much cortical height loss there is and loss of cortication and an opening, actually getting a little bit of rotation, but not much movement. And again, obviously that disintegrated disc doesn't reduce at all. So this was a 63-year-old male with a history of TMJ arthritis, and we see some marrow edema here. The disc is here. It's actually hard to see, but if we look on the coronals here, we see that there is sclerosis and really a condylar fracture of this fragment. So this is a patient with osteochondritis dissecans. Now, we look at more severe changes and necrosis in this patient. This isn't a patient with acute avascular necrosis. We look on our T1 weighted image here. We have complete loss of normal T1 bright signal that we would expect to see. Just look at this diffuse loss of normal marrow signal. We see that on the coronal image as well. There is diffuse edema, as we see on the T2 weighted images, and on post-contrast images, we have diffuse enhancement. You notice a loss of the cortex here. It's a subcondylar fracture with collapse of that articular surface here and diffuse enhancement. So this is an acute avascular necrosis. And another patient, again, complete loss of normal cortical signal here and collapse of that articular surface in this opposite side of the 63-year-old male who has an ABN on the other side. So now let's turn our attention to talking about the synovium and synovitis. Because this is something that we'll see very often in these patients, particularly with rheumatoid arthritis. And I love this cadaveric diagram showing you the condylar head, the articular disc separating into the superior and inferior joint space compartments. This is all lined by synovium. And this is an image. This is obviously an MR image. We've given contrast. Now, what we've actually done, this was a patient that we were actually trying to work up for a presumed external auditory canal fistula. So we'd actually done a conventional arthrogram beforehand, injected contrast, and then we also gave injected actually isoview, and we actually injected gadolinium into the joint space as well. And so that's what we're seeing here is the outline of the synovium with contrast here, and you can see that very nicely on this image. So in this patient with acute synovitis, you see, again, loss of cortication of the condylar head and collapse of that articular surface, some edema within the condylar head, and just diffuse enhancement throughout the entire temporomandibular joint capsule and articular disc, as we see here. So this is a patient with acute synovitis, that diffuse enhancement of the entire synovial complex within that temporomandibular joint capsule. And this was an adult patient who presented to the ER with some pain and swelling and redness over the preauricular area. And they actually thought that she'd had acute parotitis. But what we see on this contrast-enhanced axial CT is that we have this fluid enlargement of the temporomandibular joint capsule with enhancement here. You can see this on the sagittal reformats. It's really all contained within that temporomandibular joint capsule. We have fluid enlargement of that entire capsule, as well as enhancement. And we see a little bit of loss of cortication and flattening of that condylar surface here. So this is an acute synovitis and a septic arthritis. On the MR in the same patient, again, we see on the T2 weighted image here, we do have an anterior displaced disc with superior joint effusion, a smaller inferior joint space effusion, and just diffuse enhancement of that entire joint capsule. You can see that the articular disc here is completely surrounded by enhancing synovium in this patient, again, with acute synovitis and septic arthritis. And this was a young patient, a 13-year-old male who's being worked up with a concern for arthritis. And we look on our coronal T1 weighted image on both condylar heads. You see the extensive resorption of that condylar head. It's just completely flattened and really very small in dimension. So certainly have had a lot of condylar resorption in this young patient. And you can see, even I think can appreciate that there's really just sort of the soft tissue enlargement of that entire temporomandibular joint capsule, and inclusive the articular disc. If we look in our T2 weighted image, we have superior and inferior joint space effusions. And we look in our post-contrast images, we really have significant enhancement of the synovium, and you see here really pretty significant pannus as well. So this is somebody that certainly has significant arthritis with pannus formation in this unfortunate young gentleman. So Dr. Matthews brought up earlier the idea of staging of these internal derangements and degenerative joint disease, and this is the Wilks classification. That really is based both on clinical as well as radiographic staging. So in the Wilks radiographic staging, again, it's just broken down to the degree of degenerative joint changes and internal derangements. So our earliest stage is where we have either a normal disc morphology or maybe a slight anterior displacement. So you really have the very early changes in the disc, if at all. Stage 2 would be anterior displacement, again, with some morphologic changes, but you're really getting recapturing of all of this on opening. On stage 3, you have anterior displacement, again, with more progressive dysmorphic appearance. You may be getting some fibrosis, or again, a rather dysmorphic appearance of the articular disc. And you may or may not see recapture or reduction on opening. And stage 4 is where you have much more impressive morphologic changes within the disc. It's anteriorly displaced. You certainly have degenerative changes within the condyle. And of course, your most advanced stage is where you have anterior displacement, where you have perforation and really disintegration of the articular disc. And here you typically have more severe degenerative joint changes as well. So this is kind of the staging that we used. And really the template that I showed you earlier will capture these staging elements sufficiently for diagnostic staging. Now, what I want to do is just finish up the last few minutes with comparing and contrasting what we've seen with common degenerative joint internal derangements of the temporomandibular joint with other inflammatory conditions that we may encounter in the adult, but in particular the pediatric population as well. So this was a 15-year-old male with a history of right TMJ pain for several years. He had no history of trauma. And we see that we really have loss of the normal marrow signal within this, really not just within the condo, but the entire ramus here. It's hard to appreciate, but the articular disc is actually normal in him. So we really need to investigate a little bit further in this patient. And as we see on our axial T1 weighted images, we can see that the right mandibular condyle ramus is enlarged relative to left. We have diffuse loss of that normal marrow signal here in our T2 weighted image. It's a little bit edematous, but notice that the cortex is really intact. If we look on our CT images now, we see again this diffuse enlargement, sort of this ground glass appearance of the condyle ramus, if you will. But we start to notice that there are several lytic areas as well within the ramus and condyle. And on our coronal reformats, again, we see multiple lytic areas within this enlarged condyle, but we also notice that there's periosteal reaction, and I think you can see this both on the coronal, on the buccal and lingual aspects. We just kind of layered a periosteal reaction there. And if we look on our soft tissue windows here, we see that there is edema within the overlying masseter muscle. So clearly this is not an internal derangement or degenerative joint disease. This is obviously a pathologic osseous process within the mandible itself. And this is in fact Guéré's osteomyelitis. So Guéré's osteomyelitis is also called chronic osteomyelitis with proliferative periostitis. And so this is a chronic lytic and sclerotic osteomyelitis of the mandible we typically see in the pediatric population. And the reason or the characteristic finding that we find with this is this kind of layered periosteal reaction that kind of gives it this onion peel appearance to it. It typically arises secondary to a odontogenic infection. So a differential diagnosis for Guéré's osteomyelitis, of course, would include chronic relapsing multifocal osteomyelitis. And as Dr. Ballinger pointed out earlier, one of the things that we always have to be concerned about, particularly in the pediatric population, is to rule out neoplastic etiologies, which include rhabdomyosarcoma or Ewing sarcoma. And of course, we always need to think about Langerhans cell histiocytosis. So when we think about these inflammatory disorders, and we talked about this Guéré's osteomyelitis, one of the things that we need to think about is a spectrum of chronic non-bacterial osteomyelitis or chronic recurrent multifocal osteomyelitis, as we see here. So these are autoinflammatory osseous pathologies that we, again, typically see in the pediatric population or young adults. It is a non-bacterial osteomyelitis that typically involves the long bones, the spine. We also will see it in the mandible. And it has this relapsing remitting course. And it really has a large overlap with a number of other dermatologic and other spondylitic etiologies. Also has overlap with inflammatory bowel disorders. So a lot of autoimmune overlap. And as we see that here, there's a number of other pathologic conditions associated with this. As we mentioned, dermatologic disorders, other autoinflammatory disorders, GI disorders, and of course, other spondyloarthropathies, as we see here. So really something that needs to be worked up in consideration of a number of these other pathologies that have osseous involvement. Okay, so I want to just finish up our discussion here with a couple of other types of pathologies that we'll see in the temporomandibular joint. This is a 57-year-old male presenting with trauma. He had no fracture, but we notice on our axial bone CT here that we have these bits of ossification around this left condylar head. We can see this in the sagittal reformats. We captured these images with the patient opened a little bit, so you see normal translation. The condylar head is completely normal, but we see all of these areas of ossification that are clearly within the temporomandibular joint capsule, but in this case really located around the retrodiscal tissue. So this is synovial chondromatosis, and synovial chondromatosis really occurs as a result of synovial metaplasia of the hyaline cartilage. We typically will see this secondary to degenerative joint disease or prior trauma, and what we'll find are these multiple calcified nodules within the joint space. They're typically within the superior joint space, but you'll see them in the inferior joint space, so surrounding that entire condylar head. And they're usually these fragments of ossification or discrete nodules of ossification within the temporomandibular joint capsule. You see another patient here with these multiple areas of ossification or calcified nodules anterior to the condylar head. You see this here, these discrete nodules. So this is synovial chondromatosis. Now, we have to distinguish that from calcium pyrophosphate dihydrate deposition disease, or CPPD, which is a chondrocalcinosis, as you will remember from metabolic disease. Now, these when they present in the temporomandibular joint, obviously these usually present in older adults. What we'll see, generally speaking, is more diffusely calcified mass here, as we see on the medial aspect of this right mandibular condyle on our axial bone CT, and you see this on the coronal reformat, this more densely calcified mass. Although sometimes the calcification can be a little bit subtle, these will tend to enhance on MR imaging. As we see in this patient on our bone CT, a much more obvious and exuberant calcified mass surrounding the condylar head. Notice that this is well within this expanded joint space of the temporomandibular joint capsule. So it's all within the capsule, which is expanding this. You see in our T2 weighted image, it's heterogeneous T2 hyperintense, and then it is enhancing, but again, just surrounding the condylar head in this expanded joint capsule. And then as Dr. Matthews talked about earlier, our end-stage treatment for these temporomandibular joint disease when all of their modalities have failed is total joint replacement with the TMJ concepts prosthesis. As we see here, and as they showed you earlier, the different components to it, the mandibular condylar component, which is affixed with bone screws to the native ramus. We have the so plastified articular component here, and then the metallic component along the remaining zygoma. So what we're looking for in imaging, as we see here on our sagittal reformat bone CT, is to ensure that we have normal articulation of the mandibular condylar component with the articular surfaces and the glenoid fossa component. So we're looking for any sort of hardware failure or loosening, which we see. We want to see this normal relationship between the metallic components of the joint prosthesis, and also to look for potential changes on the opposite condyle, as Dr. Matthews talked about earlier in his talk, because whatever happens in one condyle is going to affect the other condyle. We certainly want to look for bone remodeling, degenerative joint changes, and any internal derangements in the opposite condyle. And then lastly, I just want to finish up here with a view of these celastic implants. We no longer put these in, and this was something that we used to use in the past for treatment of internal derangements when the disc had to be replaced, and that was to put a celastic implant in, as we see here in this older patient on our axial bone CT. You just see this mildly hypodense soft tissue band here, really in position of the normal articular disc, and you can see the clips here. We don't use celastic implants anymore because they tend to form a granulomatous reaction, which certainly can cause erosion in the glenoid fossa, and in some cases would actually erode through the glenoid fossa and into your cranially, and your temporal lobe is really not a fan of celastic. So we no longer put these in, but I did want to just show this to you. You will sometimes see these rarely in older patients. And again, what we're looking for in those that still have them are any evidence of condylar resorption. You can just see a little bit of remodeling in this patient who fortunately never had a severe reaction to this. And so this is a patient with a celastic implant. And I think I will finish up here and entertain any questions.
Thank you so much, Dr. Mosier, for the excellent talk as always. So any questions from the audience, from our fellows and trainees at IU? Okay. Hey, I have a couple questions for you guys. So in terms of the internal derangement, when the surgeon talk about and when we talk about, is it the same meaning, like a displacement or fragmented of the disc?
Yes, yes, that has the same meaning.
Same meaning, right? So when we see like a fragmented or like a displacement or anything, we can call displacement, or we can call internal derangement.
Yes.
Okay, yeah. And for Dr. Matthews, you mentioned something about like you need to check for the vascular structure, like a maxillary artery before any procedure. Does it mean that you want the CTA before surgery every time, or do you need that one? Okay.
No. We don't need a CTA every time. There are certain category of patients for whom I would definitely get a CTA. The two, in fact, broadly speaking. One is the multiply operated patient, patients who've had multiple procedures on their temporomandibular joints, where there's a lot of scarring around the joint. Typically what scarring does is that scarring will pull the internal maxillary artery and the structures just medial to the condyle, close to the condylar head. So I want to know, before I go in there as a surgeon, I want to know exactly how close that internal maxillary artery is to the condylar head, especially if I'm going to be resecting the condylar head. What we don't want to do is end up with a major bleed on the operating table. So the multiple operated patient, I would almost always request a CTA for sure. The other patient group are those with ankylosis, actually, those with a lot of heterotopic bone formation, because again, the anatomy can be very different, very aberrant. So the ankylosed patients, like I showed you in some of my slides, typically the internal maxillary artery will be very up close and personal to the medial aspect of the condyle. So again, I want to know where that is before I get in there. And often what I didn't show, what I will do is I will get a CTA and get either the interventional radiologist or my neurosurgical colleagues involved, and we'll embolize the IMA preoperatively before I take the patient to the OR. And I've done a lot of those in the last 6 to 9 months, actually. Curious, I've had quite a few patients who required embolization of their IMA.
I see. Any questions from our fellows here? You make it clear. So Dr. Ballinger, I have a question for you, because like a majority of our patients, which is a pediatric patient, and I mean, sometimes we need to do the study under sedation or GA. So it's maybe like a limitation to open and close mouth position, but we can give contrast for sure. Are you okay with that, just like a post-contrast images, if we cannot have an open and closed mouth position or dynamic study?
It's a good question. I think I would defer to Dr. Mosier. I think we do the best we can with what we have, right? And certainly in the very young patients, we know under sedation, it's really hard to get them to open and close, if not impossible. So I would say it'd be okay. But Chris, since you're on, would you?
Yeah, I mean, it's in that case, really what's important is we're really looking for the degree of inflammatory change. So having the contrast and looking at the degree of synovitis is the most important thing, where we have to have that trade-off of really being able to determine what the mobility is. In that case, if we can't do any opening maneuvers because they're under sedation or general, then we can't. But the most important consideration in those patients is really the degree of synovitis in them. So if we can get open and closed views, great. If not, really what we're interested in is the degree of synovitis.
I see. Yeah. So it's like a follow-up question on that things, because on our templates, we talk about like a rotation when we check on like the movement, right? So how do you evaluate the rotation? Because when we do the cine image, it's just like a 2D image. We can see like a move up, anterior and posterior. But for the rotation, it's like a turning or something that we should see.
Well, so it's if you see my hands, pretend that my wrist here is the articular eminence. Your joint is going to rotate first and then translate, right, as we saw in our video, right? So it's a subtle movement sometimes. So it's going to rotate like this and then translate. So sometimes all you see is a little bit of rotation. You won't necessarily see a lot of rotation. So it's really one fluid movement, but there are actually two components to it.
Okay.
And
so
yeah, and it's hard, because the cine images go pretty quickly. Even though it's 2D, you can see those two different elements of the movement. But yeah, you have to look at it pretty carefully and just keep watching it. You'll see it.
I can see like an anterior and posterior movement, but for the rotation, sometimes like what are you talking about the rotation? I cannot see it very well on the cine images.
Yeah, as I said, sometimes it's tough to see it because it's going to be one smooth movement. So it's hard to pick up the actual rotation component of it, but there is a rotary component to it, and it's really in this superior to inferior rotary component to it. So it's not a side to side thing. So you can see it within the cine images, but you have to look at it pretty carefully.
Okay, sure. Thank you so much. We have the audience from Thailand who is like my co-moderator in here. So I'm not sure that she has any questions here or not, as like a Thai representative in these lectures. Namphon, Dr. Sinchai.
Yes, good morning. Can you hear me?
Yes,
can you hear me?
You.
Yes, we can.
Yes.
Okay. สวัสดีค่ะ and good morning, good evening from Thailand, but good morning from your area. Okay. in my experience, I have not much case in TMJ disease, maybe due to several issue. Maybe some patient cannot come to hospital, or imaging is quite limited in some hospital too, because some spatial techniques. So can I ask about the image that the sequence that can differentiate the excuse me, about the imaging checklist that you already told us about TMJ. Can you please repeat again?
So the template that we were.
Yes, imaging checklist for interpretation.
All right, let me just pull that back up. Let's go. Give me just a second here.
I think it's easier for us when we have the templates. We just follow like your step, Dr. Mosier, and okay, this is what we need to read and check and tell the clinician, tell Dr. Matthews and Dr. Ballinger on the important information.
Yes, I think it's very useful for us to recheck.
Okay, so can you see this?
Yes, we can see the screen.
Yeah, so this is the template that we would use. So these are all the elements that we go through and look at when we're interpreting our MRs of the temporomandibular joint. And we actually have a template that addresses each one of these components. So we're looking at the position of the condyle as it sits in that glenoid fossa, as well as its morphology. So again, we're looking at if there's any loss of cortication, if there's any flattening. We're looking at the marrow, the signal change to see if there is any marrow edema. We're looking for the joint effusion, which is really what we're using those T2 weighted images for. And then, of course, the positioning of the articular disc. Is it displaced? And are there morphologic changes to it? Is there thinning? Is there fibrosis? Is there perforation? So fibrosis, typically we're seeing an increase in the T1 signal there. And sometimes what we see, and this is something that Doctors Matthew and Ballinger and I have all talked about, is sometimes you'll see that intermediate zone will get really, really thin. It's like less than a millimeter. And that really is a very thinned articular disc. And then when we've been talking about the degree of synovitis. And so obviously we're looking for the amount of synovial enhancement. And you can see this is a relative scale. We don't have quantitative measurements of this. I mean, what's mild, moderate, or significant? Again, unfortunately, in the literature, there really isn't, a certain amount that we can say, yes, that's definitely mild or definitely moderate. It's really kind of a subjective, qualitative assessment. And then again, the mobility that we've been talking about. So does that address your question?
I cannot hear you, Namphon. You are muted.
Yes, it's very useful to check before interpret and communicate with the physician. Thank you so much. Can you hear me?
Yes, we can hear you.
Excuse me. Okay.
Okay, so if you guys any questions or comments? Okay, so if not, we have I send you a evaluation form on the chat box. So for the trainee from IU, please complete the evaluation form for us. And for the Thai audience, we will send the evaluation form to you. So please complete the evaluation form by Friday midnight. So you will get the CME credit on this when you attend this event. And for the IU people, you can text the message to get the CME credit as well. You get the 2 CME credit for this 2-hour lectures. And thank you so much, our speaker. You always give an excellent talk and teach me a lot. I have learned many things every time when I listen to your talk and see like the technique and how to treat the patients and also the outcome. And thank you, Dr. Mosier, for teaching us as always on the imaging. I think this is a very challenging topic and very difficult imaging modality to read but you simplify those things for us. Thank you so much, everyone. So
Thank you, Tanya.
thank
you for having
you.
us.
Thanks.
Thank
Bye,
you.
Thank you
everyone.
so much. Thank you so
Bye-bye.
much.
Pleasure. Lovely to
See
meet you all.
you.
Bye-bye.
Nice to meet
Bye.
you.
Bye bye.